Well, it's my pleasure to have contributed a chapter discussing the neurologic endpoints in clinical studies. Why is this so important? It's so important as we do everything else in cardiology. We need to speak a common language when it comes to our clinical studies. And I think in no area more than neurologic endpoints was there so much confusion, diversity, lack of standardization. And that was ultimately the purpose of NeuroArc, was really to develop that common language. We brought together neurologists, cardiologists, surgeons, neurocognitive specialists, and experts, as well as imaging experts. The FDA told us they were very much in favor of us doing this, but they wanted consistency with prior definitions. So it was no easy task. If you go to the chapter, you will see it's all summarized in a very simple table. That one table took us over a year to summarize. But it's all summarized there on the basis of two things: the presence or absence of symptoms, and the presence or absence of documented neurologic injury on brain imaging. And there are basically three categories of neurologic injury, and I'll let you read the details in the chapter. How do we implement this in clinical studies? Again, my strong advice is to collaborate, as we always do in our studies, with these subspecialty colleagues, whether they're neurologists, neurocognitive experts, or qualified core laboratory. The diffusion-weighted MRI reads are very complicated. They do require expertise, and I don't believe that you can do one of these studies without bringing that expertise to the table. So I hope you enjoy the chapter, and thanks again.